Today we will tell you another small pearl in interventional radiology, and that is how you can use CT to access a very difficult vessel. Not only to access, but like what we talked before, it can help you decide what is the right diagnostic catheter, what is the perfect working angle, and thus allow you to access a vessel which otherwise can be extremely difficult. So just yesterday we had to treat a patient with hemoptysis. The treatment was done by one of our doctors who are training with us, but we planned this case together to ensure that we could successfully treat this patient. So this is the CT scan. Now if you look at the axial views, you can see there's nothing down, but as we come up, this is the bronchial artery, and you can see this vessel arising from the arch. Obviously on this view you cannot plan how to access or treat, except that you know it's a small size vessel. If you do a multiplanar reconstruction and you place this cursor exactly at this spot, what you can do is you will actually get to see where the vessel takes off from. So if you see in this, can you see this here? This is the takeoff of the vessel. It's a very, very odd location. Technically looks very challenging, because if you see the volume rendered image, you can notice that this is coming out from the inferior aspect of the arch. But if you truly look, now this is actually the anterior posterior view. Okay, if you see this, it's not exactly where you would want it to be. That is the inferior concavity of the arch. Have a look at it from posteriorly. You can see it's arising at this rather awkward point. Now when you see this, you realize that there are some problems that you will face about one, what catheter would you use to access, and what is the angle in which you can actually profile this aneurysm, this vessel, to hook it. So we want to show you something that is possible on modern CTs. Now this is the ostium. We are very clear, right? But how do you get to see the ostium? In many of the new machines, have a look at this point. It says LO 30 degrees and a caudal of 40 degrees. Now this is what will help you enormously. Now you know, if I keep this patient on a flat AP, if I take the tube to an LAO of 40 degrees and give a caudal angulation of 40, I can actually hook this vessel and do it. LAO of 30 and a caudal of 40. Now which catheter would you choose? If you look at this, you realize hardly any catheter will sit over here. It's a very, very wide aorta. I'll measure that to show you how wide it is. Now this is the aorta, which is going to be like 3.4 centimeters. So the classical cobras won't go. A C3 may hook, but may not be a stable position. So one of the catheters you may never think of using, but which can be very successful, is a Judkins left coronary catheter. It is not made for this, but it's one of the best catheters in this difficult location, and you get it in different sizes depending on the secondary curve. It is like 3.5, 4.55, so or 3.545. So we thought of using a Judkins left 5. Okay, so let's see how the angiogram actually went. So this is at an LAO of 43, caudal 7, which is not the appropriate angle. When it's not in the appropriate angle, you will not see the takeoff of the vessel at all. This one, on the other hand, LAO 43, caudal 21, and you see we have taken a steep caudal. We are given an LAO 43. There we said 30, 40, but somewhere in the right, can you see this catheter goes and hooks into this? This is the artery. And that's why we said the Judkins left works well. The secondary curve is pushing from the outer curve of the aorta, allowing it to go. And now that you have profiled the origin, you enter this and you successfully treat it. So after that, of course, treatment is not difficult. As you know, it is a very, very standard treatment that you would do, right? So this little bit of information on how a very difficult vessel can be accessed very easily without too much time by finding out the working angle from the CT and deciding an appropriate catheter that would fall into it. So that's a simple talk just to give you an idea on how to hook a difficult vessel. Now the same thing can be done for any other vessel. So the second case we want to show you is a patient who has come to us with progressive renal failure, uncontrolled hypertension, no renal artery on the left side, a critical stenosis on the main renal artery on the right side, and also a critical stenosis in the accessory renal artery. Now you see this is a very badly diseased aorta and sometimes can be very challenging to enter the ostium. Again you can do the same thing. You can find out the angle LAO 29, caudal 7 on this and again decide what is the catheter that you require. So for this it was pretty straightforward. We actually used the renal guiding itself, could cannulate this and do an angioplasty. Whereas in this difficult one, we actually used internal mammary artery catheter through the renal guiding catheter. So the internal mammary artery catheter would just hook the ostium, allowing us to take the small 2 mm vessel and do a stenting for this also. Let's now have a look at the DSA image to show exactly how the same picture can be replicated on the other side. So see exactly what we have done over here. We have taken LAO of 26 degrees and we get the ostium out here and that making it possible for us to enter this vessel. You can see this is a roadmap showing this. We actually got it right out here and we are able to cannulate the renal artery. Now remember this patient has got renal dysfunction, so we are kind of careful about the amount of contrast we use. So that we have crossed it. It didn't take too much time. It would have taken about 4 to 5 minutes to do this case out here and then the rest of it is standard protocol, right? We go ahead, we have the vessel wire across it, we have the stent across it, we position it appropriately, we do a dilatation and we have the result. And the same thing can also be done for the opposite renal artery. I can just show that to you again. So this is what I said, the curve that we had created. In this case we used, you can see the renal artery coming here. The curve we have got is a combination of a renal guiding and an internal mammary artery catheter. And here we have taken this across and the wire across, and of course after that is a standard procedure. So I hope you got the hang of accessing a difficult vessel which otherwise may take a lot of time in the cath lab by making full use of a good CT with a workstation which allows you to see the volume rendered images where you can actually see the working angle. The best part of it, the CT need not be done in your hospital, even done elsewhere, you can still get this information and treat. So thank you very much. I hope you enjoyed this little talk that I gave this morning.